So, as I mentioned, these are the key findings from a citizen panel that we hosted on strengthening end-of-life communication and decision-making in Ontario. So we brought together a group of citizens from across the province and from across all walks of life to discuss this very specific issue for a one-day conversation about how to improve communication and decisions about end-of-life care. The funding for the citizen panel was received from two groups, the McMaster University Labarge Optimal Aging Initiative, as well as the government of Ontario through a research grant that we received. We had two scientific collaborators on this project, Julia Abelson, who's an expert on public and patient engagement, and as well as John Lavis, who's the director of the McMaster Health Forum. What was interesting about this specific panel is it followed a stakeholder dialogue on the very same issue. So just a couple of months before the citizen panel, we hosted a one-day dialogue with health system leaders from Ontario to talk about end-of-life communication and decision-making. And during that event, a lot of people mentioned, well, we need to hear from citizens from the province about their thoughts and values around end-of-life communication and decision-making. So this is why we decided to host a citizen panel dedicated to that topic. So why is this such a priority? Why end-of-life communication and decision-making is important? So as you may know, despite the desire of many people to achieve greater control over decisions about end-of-life, most do not have a plan for end-of-life care. And we do have some statistics about this. And this issue is particularly important given some of the aging population, the fact also that we have a growing burden of chronic diseases and life-limiting conditions and very complex care needs. We also have new advances in healthcare that promise life-saving or life-prolonging possibilities. So in that context, the number of people who will be facing these types of complex decisions is really increasing significantly in coming years. For those who may not be familiar with the format or the mechanism of the citizen panel, essentially it provides the opportunity for a group of citizens to read a plain language citizen brief, which is a short document that introduces an issue. So they read the document, they discuss with their family, they reflect on their own, and then they are brought together to discuss for a one-day discussion on an issue. During the day, it's a series of facilitated discussions, and the purpose of the panel is essentially to uncover unique understanding about a health system issue. It could be a completely different way of framing a problem, could be insights about viable options to address a problem, and most often it's quite useful to better understand the values and preferences of citizens regarding a health system issue. In terms of the profile of participants, we hosted a series of panels on palliative care, and this very specific one was on end-of-life communication and decision-making. It was a fairly small group, about 9 participants. Some unfortunately had to decline due to chronic illnesses and caregiving responsibilities, but they came from across the province of Ontario. It was interesting to see for that panel, we had a very wide range of ages. Usually we have a tendency to have participants who are a little bit older, but for that specific panel, we were able to recruit some participants that were in lower age brackets. All the participants were selected based on explicit predetermined criteria from a research panel called Asking Canadians. So it's a pan-Canadian panel that exists with thousands of people from across the country. And so when we set up a citizen panel, we define our inclusion-exclusion criteria, and then we send targeted invitations to members of the Asking Canadians panel. The citizen brief is actually available. So if you want to have a quick look to the citizen brief, it's available on the forum website. But essentially, it's structured in this way. We have a brief section describing the context for the citizen panel. We have a brief section describing the problem. We also have a section describing 3 options to address the problem. And these options are essentially prompts to discuss. We're not forcing people to focus on these 3 options, but we ask them to think about potential options to address the issue at stake. For the purpose of that citizen panel, we had 3 options. The first one was to improve public awareness about end-of-life care. Second one, looking at how can we engage citizens in a province-wide dialogue to encourage open discussions about end-of-life care. And the third option was to provide citizens with the tools and the information they need to engage in advanced care planning. And the last section of the report focused on implementation considerations. So if we want to move forward to improve end-of-life communication and decision-making, what are the type of considerations that we have to keep in mind? What are the potential barriers, potential facilitators? So this the group that took part in that one-day event. We had a fantastic group, and it was quite exciting for the forum since it was the second panel that we hosted. We have now hosted more than 20 panels on various topics, but it was, the very first set of panels where we started to fully develop the citizen panel program at the McMaster Health Forum. So now let's jump into some of the key insights from the citizen panel. The first one was an insight about the public. And that's something that may not be new to you, but few people engage in a end-of-life conversation with their families and friends. But when they talked about the lack of conversation, the participants really focused on 4 elements that could explain, could provide some reasons why we don't talk about it so much. The fact that some people actually are in denial about that, the fact that end of life and also end of life care more specifically is such a very personal issue, and people may not be really inclined to talk about it openly. The fact also that end of life conversations may generate fear among some people, and even a lot of people said, there's a fear that talking about death will precipitate death. So if you have a chronic or limiting chronic conditions, starting to think about advanced care planning may potentially precipitate death. And lastly, the fact that certain ethnocultural communities that may be less inclined to talk openly about end-of-life care issues was really emerged as an important issue, especially for the province of Ontario and the rest of the country. So here's a little quote that kind of expressed the stigmatization around death and the difficulty of talking about end-of-life care wishes. So it is a quote from a citizen panel member. The media glorifies the fight, doing everything to fight the process of dying. He didn't stop trying. He pushed back. He's a fighter. And this is why it's hard for people to see that it's not necessarily giving up as other people would see it. Another insight from the panel is that advanced care planning is really new to most people. When we use the expression advanced care planning, nobody really knew what we were talking about, and then we provided information about what it is, and then it made sense. It really resonated with participants. What came up from the panel is that everybody seems to be very familiar with the power of attorney for personal care. They have an understanding of that legislation, and they saw the value of advanced care planning concurrently in complement to the power of attorney for personal care, so that whenever we talk about advanced care planning, we should also talk about that other legislation. A third insight about the fact that we have a changing culture. So although there's still a lot of stigma, a lot of people are concerned about that, about talking about death and their end-of-life care wishes, participants indicated that we have a changing culture that's more favorable to end-of-life conversations. And they also focus on two elements to explain this changing culture. The first one is that people want greater control over the last stage of their lives, and they want to have peace of mind. They want to make sure that at the last moment of their lives, everything will be clear, crystal clear, their preferences, their wishes, so that they don't leave something to their caregiver or substitute decision makers to make a difficult decision for them. Last element is that people are paying greater attention to quality of life and not just longevity. And that's why they believe that people are getting a bit more comfortable talking about end of life and end of life care. The discussion then turned to the role of professionals, and there was a lot of uncertainty about which healthcare professional citizen could or should talk to about their end-of-life care wishes and advanced care planning. They really wonder who has really the time to engage in such conversation, especially if you have a healthy patient, and who has the expertise to discuss end-of-life care issues. The discussion kind of naturally turned to the role of family physicians, and the participants said that for the few who had access to a family physician, they believe that they were not necessarily in the best position to engage in end-of-life care conversation, and that was an interesting conversation that we had about this. Many people indicated that they don't necessarily have a good rapport with their family physician, or at least the kind of rapport that would allow such conversations to take place. There was also a perception that family physicians lack the expertise in this area, and that people would be probably more inclined to engage in conversations with healthcare providers who actually deliver end-of-life care. Another key insight from the panel, just before maybe another quote from one of the panel members about the role of family physician, which was interesting, is how often do you really see your doctor? And it's a personal issue discussing end-of-life care wishes. They know my body, they know my health, but they are not involved in my life on a daily basis. So that kind of quote reflected the uncertainty regarding their family physician and the role that they could play in these types of conversations. There was also a discussion about the system in place, and participants were really concerned about potential risks of communication breakdowns. So participants were worried that there was a lack of availability or knowledge of existing advanced care plans and express wishes for end-of-life care. And there was also a concern about the lack of system in place to actually store these advanced care plans. So even if we have a plan, where are they stored? Is there a registry? Is there some place where people, for instance, my substitute decision maker, will be able to go and actually find my advanced care plan and so on? Will the doctors providing me end-of-life care will have access to some sort of registry, some sort of place where they can find my plan? So that was a big source of concern for citizens. Another interesting quote from one of the participants is they kind of summarize all the problems that we were facing. And they said a lot of times things that crop up as problems are really nothing more than a failure to communicate. And really, it kind of summed up all the problems that we're facing in the system right now, a failure to communicate. The sixth insight that we had is that when we look at the options that we propose to participants, as I mentioned before, we had 3 different options. The first option was about improving public awareness about end-of-life care. So kind of creating some public awareness campaigns, and we know that some currently exist, such as Speak Up and others. And that option really resonated with participants. They thought that it was a promising way to address the fear and stigma associated with end-of-life conversation, and also to encourage people to actually engage in advanced care planning. And when they talk about that option, they kind of identify 3 key values that should guide the development of public information, public awareness campaigns. The first one is that it should be people and family-centered. So these campaigns should really be attuned to their needs and values. These campaigns should also focus on a shared responsibility to get the conversation going. So not just the responsibility of citizens, but of civil society overall. And also, these campaigns should focus on collaboration between the health system and all the other sectors that could help get the message out. When they turned to the second option, which was engaging citizens in a province-wide dialogue to encourage open discussions about end-of-life care, there was a really interesting discussion, and there was a lot of divergent views about the value of a province-wide dialogue. A lot of people said, well, the topic may not be conducive to a vast public dialogue since it's mostly dealing with personal and private matters. So your wishes for end-of-life care shouldn't be debated in public. They also mentioned that, yeah, maybe a province-wide dialogue is not interested, but maybe there's a value for smaller and more culturally focused dialogue in very specific ethnocultural communities that may not be really inclined to have these type of conversations. And when they talk about option 2, there was 2 key values that emerged. The first one is privacy. Someone's wishes for end-of-life care are private and should not be debated. They also focus on community-centeredness, so these awareness campaigns and dialogues should be attuned to the needs of particular ethnocultural communities. So, and probably Daren will have some thoughts on this option as well and what came up from the panel, but again, the tension, there was an interesting tension when they talk about option 2, the fact that there's so much stigma out there about death, about talking about your personal wishes and preferences for end-of-life care, that we should talk about it more, but not necessarily in a full dialogue across the province. So it kind of revealed that a lot of stigma around this issue, and also maybe the confusion between having a dialogue and having a debate. So I think some people were unsure if we could actually have a real dialogue versus an actual debate on this issue. Another insight was that it was about the third option, the need to develop and provide some information and tools so that citizens are able to engage in advanced care planning. And the participants identified 3 types of tools that would be really useful. On the one hand, they need tools to learn about advanced care planning. They need tools to complete advanced care plans. They also need tools to communicate the advanced care plan or make people aware of its existence. So it could be an electronic registry, a code on the OAPE card, a bracelet, a tier of cards given to other people. We know that some of these tools currently exist, such as wallet cards and so on, but I think these types of tools would be extremely useful to citizens. And they felt that these types of tools could support greater empowerment, and also that if we develop these types of tools, we really need to focus on credibility. So those who develop and endorse these information tools and should really be extremely credible. And when they look at all the options that we proposed, they said that really sequencing is key. So they were not too keen about option 2, but they were really keen about option 3 and option 1. And they really emphasized the fact that option 3, creating the information and tools, should always precede option 1. So it will be more fruitful to focus on efforts on developing the information and tools that citizens may need to engage in advanced care planning before launching the full-scale public awareness campaign that could generate a lot more demand for these types of tools and information. And lastly, the last key insight is when they look they try to look forward. If we want to improve end-of-life communication and decision-making, what are the type of barriers and facilitators? I think they really, again, the issue of stigmatization came up. They said that there's probably going to be a lot of challenges in trying to mobilize key civil society organizations, because a lot of these organizations will be cautious about being associated with death, with mortality, with end-of-life care, and so on. So these are the top 10 insights from the citizen panels. We'll have some time to discuss these, and you may want to maybe talk about what insight resonated with your own personal experience and professional experience. But I'll turn to Daren for now to talk a little bit about end-of-life care communication and decision-making in the country. Daren?
Hi, yeah, thank you, and sorry for joining late. Had some technical troubles. François-Pierre, is this the first part of my slide, or can I jump ahead just because we're a little behind?
I believe.
Daren, I just put it at the first slide, but you can jump ahead as you'd like.
Okay, and I have controls.
You do. If you just use the arrows at the top of the screen there. There you go.
Okay. So I guess why we're all interested in this subject, and sort of a spoiler alert, is that we all are going to die. And I'm particularly concerned as an intensivist that if we don't plan well for that eventuality, that it will go poorly for us at the end of life, as illustrated by this anecdote, this letter of a woman who wrote me a letter saying, hey, you know, my husband died in your emergency room, and someone should have known that he needed palliative care and not sort of intubation and transfer to intensive care. So it's about trying to improve the quality of end-of-life care in Canada. For us as a research group, we stepped back and said, well, what do we mean by defining quality end-of-life care? And we surveyed hundreds of patients and their families to figure out really what's most important to them at the end of life. And I won't go through this in detail, but just to say that these items that ranked as extremely important to them could be couched in or are all relevant to aspects of good communication and decision making. In fact, we went on from that to create a satisfaction instrument, which we juxtaposed with ratings of importance. So on this grid, which actually something's wrong with that line, I'm not sure why it's coming tangentially across the screen, but this grid is comparing satisfaction with ratings of importance. And so if I focus on that upper left-hand quadrant, which is things that people say are most important to them, that they're the least satisfied with, each of those dots is an item on a questionnaire that is illustrated here in this next slide, where these are the aspects of care that patients say, you know, this is really important and I'm not very satisfied. So it has to do with relationships with doctors, and it has to do with communications and decision making. So what I'm trying to say is that we can make the greatest improvements in end-of-life care by improving end-of-life communication, decision making, inclusive of advanced care planning. Just to be clear of what advanced care planning is and what it is not, I just want to use this slide to set expectations or define exactly what I mean by advanced care planning, which is usually decontextualized from the medical encounter. It's people thinking about values and wishes and preferences and choosing a substitute decision maker. It's not about people specifying in advance the kinds of treatments that they do or do not want in the future. That is more of a goals of care conversation where in the moment a patient and or their substitute is discussing with a physician the problem that faces the patient right now and the kinds of treatments that should be used. And specifically, we talk a lot about the use of life-sustaining treatments such as mechanical ventilation or resuscitation, where we go through a process of informed consent and we're following healthcare law to say that this patient should get or not these different kinds of treatments. And it is so much more helpful when we as clinicians are engaging patients and their families who have been through an advanced care planning process so that they're prepared to engage us in making these kinds of difficult medical decisions. So we're all about increasing advanced care planning so that we're preparing patients and families to be with us when they are sick and when we have to make decisions. So François-Pierre presented sort of the results of that panel discussion, which led to some very interesting insights. I'd like to sort of move forward and think through then where do we go from here and sort of tie together both insights from the panel and things where we as a research community interested in improving end-of-life care and communication are going. And clearly there needs to be a multifaceted approach to solving some of the challenges that face us, no simple solution. And we've sort of broken our strategies into sort of different strategies for the different stakeholders. And to start with, I'll use this icon or this image from an infographic that is part of the Speak Up campaign, where we're trying to normalize that conversation about advanced care planning, about end-of-life care. We acknowledge, as came out in the citizens panel results, that it's a difficult subject to talk about. People have this idea that it's personal, sensitive material, and it is all of that. However, it's very much a public experience. You go to a public hospital that's publicly funded to have your death experience attended to by total strangers. So if we keep stuck in this idea, oh, this is a personal subject, I don't want to talk about it, it will go poorly for you at the end. In contrast, if we can break down those barriers and engage in public dialogue to enable us to be on the same page and plan for the eventuality of our death, that type of conversation, public conversation and planning will be most likely associated with a better death experience. And that's the aegis behind the Speak Up campaign, which is a national program trying to create that public awareness, create that public dialogue, create comfortability talking about death and dying in the public space. And there's a website, there are tools both for lay people as well as professionals, as well as community organizations across the country to enable them to start to have that conversation. Here's a great example of a workbook that this group produces that from start to finish, explains what advanced care planning is, different terminologies, and then asks them critical questions that a person has to work through to help them clarify their values and think through what's most important to them and start to begin that planning process. In particular, the naming of someone that will step up and be their advocate in the eventuality that they are not competent or capable of speaking for themselves when they're seriously ill. One of the results of our key findings from our work is that clinicians are reticent to engage with their patients in this decision-making because they feel like they're ill-prepared. They don't understand the subject matter. They don't understand the risks and benefits of different life-sustaining technologies that we use. They're ill-prepared, emotionally speaking, to deal with the topic of death and dying. So if we are to move forward and make improvements in end-of-life communication, we need to do a better job of actually preparing our patients in the system to be key informants about their own values and preferences, understand how decisions are made, and to capacitate that substitute decision maker along the way so that when the patient can't speak, there is a knowledgeable advocate. On the slide, I'm showing you an example of a preparatory tool that in fact is called Prepare. Prepareforyourcare.org. Rebecca Sodori, an internationally renowned geriatrician palliative care physician from San Francisco, has produced such a tool that people can work on offline, off to the side. They don't need necessarily, a healthcare professional to walk them through it. They can work on this independently and come out of that encounter with this web-based module better prepared to talk to their loved ones and talk to their doctor to get the medical care that is right for them. A big part of advanced care planning, which is what is being illustrated in the Prepare website, is what we call values clarification. And I'll move through these next few slides quickly. I'm just trying to give you examples of what I mean by values clarification, where in these questions here, the patient has to respond and show their preferences or leanings for questions that have competing objectives or have trade-offs between quality and quantity. So for example, I believe my family member would doctors and nurses to do everything possible to keep me alive for as long as possible, or my family member would want a peaceful death that doesn't involve being connected to machines. So which is it? These are competing objectives, and there's a slider response option that the respondent would indicate. Is it more about keeping the patient alive, or is it more about a peaceful death? Just as an example of what I mean by a values clarification tool. Here's another example of a values clarification tool where we're, again, trying to get the respondent or the patient to give us an indication as to their willingness to put up with some of the benefits of ICU treatments and some of the risks of ICU treatments, which means if you survive, you're going to be alive, but in a reduced functional capacity or reduced quality of life. And by them scoring their willingness, we get a sense of the types of treatments then that are best for them. There's no right or wrong answer here. This is about people given the tools to express themselves, their values, what's important to them, that enables us then to link those expressions to treatment preferences. Here's another example of a tool we're working on in our research setting right now. We call it a best-worst scaling, where we present the patient 4 different value statements. They rate which one is most, or rank which one is most important, which one is least important. We repeat that exercise 7 times, presenting to them different clusters of these value statements, and with those rankings we can create a final ranking of which item is the most important to that patient. So on the bottom of the slide, I'm showing the output of this best-worst scaling tool that helps us as clinicians understand that relative to these other value statements, being comfortable and suffering as little as possible, avoiding machines, and having time with family are the key things that are most important to this person, and that can then be informative when we talk about treatment preferences. The other part that we're developing to better enable our patients to speak to clinicians are decision aids, where we go through what a decision is, what the intervention is, its risks and benefits and outcomes, and things that one should consider. So CPR, cardiopulmonary resuscitation, is perhaps our best prototype example, where we've got both a paper-based and a video decision aid, so that if someone wants to be resuscitated, they should be informed by going through this process that explicates the nature of the decision, the risks and benefits of CPR. Here's another early prototype example of the level of care decision aid. So trying to contrast ICU or medical or comfort care and what the risk, benefits, and outcomes of these different strategies are, so people can make better informed decisions about their future care. Here's an example of in the ICU, trying to help families now who are advocating for their critically ill patients to make better decisions about the continued use or perhaps even the withdrawal of life-sustaining treatments, so that we can make better decisions. So I just moved very quickly through several examples of tools targeted to patients and or their families. We can bundle some of that together into a care pathway, which is, again, currently under evaluation in our research group, where we'll put several tools together with the goal to better enabling the patient and or family to decide what treatments are best for them. This is actually situated in primary care. So before patients get really sick and contact the healthcare system, our goal is to actually educate or capacitate or even activate the family and the patient so that they are knowledgeable, they're able to engage different doctors across the healthcare system about their values, about their preferences, about what's right for them. I know there was some expectation that primary care doctors do this capacitation, and it's not so much that we expect the doctor to do the capacitation, but these tools can be used by any non-physician facilitator that will walk a patient through a set of tools to enable them to come out of that encounter and then go engage, whether it be their primary care doctor or the specialist in the hospital or somewhere else in the system. So we're less dependent on the system. There were some issues around the communication failures across the system, the lack of transportability of said documents. But in fact, if we capacitate the patient and the family member to know how to articulate their wishes or carry documents with them across the system, then we'll begin to solve that problem of system breakdown or lack of transportability. And so that's what this pathway aims to do. Although it's situated in primary care, it's not dependent on primary care physicians per se. I have to acknowledge, though, that despite capacitating patients and their families, we do have to have some strategies that will upregulate the skills and comfortability and motivation of our healthcare professionals to engage in this conversation. And just like we have the Speak Up campaign for lay people and for patients, we have what we call the Just Ask campaign for healthcare professionals, where we have documents on our website that are guides or coaches, provide scripts or a roadmap of questions that healthcare professionals can ask in order for them to engage their patients and families. And in this instance, advanced care planning. But on the next slide, we also have sort of the same conversation guide to goals of care with patients who are seriously ill. So we want to acknowledge that we have to train or better train our healthcare professionals, and we have some training strategies to hopefully enable that. And finally, I don't think we're going to make a lot of progress in this space unless we engage administrators and healthcare decision makers to invest in and hold accountable the system for performance in this space. It surprises me really that we have a healthcare system that provides very expensive, non-beneficial medical treatments at the end of life, treatments that weren't wanted in the first place, and yet it's allowed, it's paid for, it's funded, so we provide poor quality care that's funded from public dollars with no accountability, no quality indicators, no measures that people look at the leadership level to say, oh, we're providing good care at the end of life. In fact, we're providing poor care that's expensive care, and decision makers really aren't sort of focused on that. And so until that happens, we won't see the kinds of policies and procedures that need to be put in place, that kind of focus on training and capacitation of healthcare professionals, won't happen until the system demands it of us. And so there needs to be some attention paid to convincing the decision makers in our healthcare system that things need to change if we're going to make some progress. So, and we tried to make it easy for them by creating such a sort of a framework or a list of quality indicators for people to look at to know how the system is doing. But to my knowledge, to date, they haven't been utilized. So in summary, there are lots of problems as illustrated by the citizens panel. Or to say that differently, there are lots of opportunities for improvement. And if we can improve communication and decision making, we're likely to have sort of the greatest impact on improving end-of-life care for Canadians. But there's no simple fix here. I think we need a multifaceted strategy that targets the different stakeholders in this conversation to create that public awareness amongst our lay public, better capacitate and enable our patients and family members so that they're better prepared to have these conversations with healthcare professionals, greater emphasis on training and capacitation of healthcare professionals to have these conversations, and then some attention paid by our system leaders so that they put those policies and procedures in place to ensure all of that happens. So I'll stop there and turn the time back to you, François-Pierre or Stephen, to sort of moderate the next steps.
Thanks, Daren and FP. I'll just move our slides forward a bit, and if anybody has any questions at this point, if you could just use the chat box in the bottom right-hand corner of the screen, and we can we'll address those as they come in. FP, did you quickly have any comments or anything to what Daren mentioned there?
Thank you, Daren. Thank you, Stephen. I'm kind of curious. I see there, do recognize some of the attendees. It would be interesting to get their perspective on some of the insights that either Daren provided or I provided based on the citizen panel. So I'm looking at the chat box right now in case you would like to ask either a question or provide some comments regarding end-of-life communication and decision-making.
That's an excellent point, FB. We certainly hope that if anybody has any particular insights, either from what FP shared or from what Daren mentioned that resonated particularly strongly with you, that would be great to see. And likewise, if you have any questions for either of our panelists today, just don't be shy. Use the chat box, and we'll certainly address those as they come in. So while we're waiting for any questions, though, FP, was there anything that, I mean, I know you shared the sort of top 10 insights, but following Daren's overview, was there anything else that you wanted to add or anything that, related really, closely to the insights from the citizen panel?
Yeah, well, maybe one lesson that I had from working through the stakeholder dialogue and the series of citizen panels that we did on this topic is actually trying to kind of grappled with all the legal arrangements right now. It can be potentially confusing to John and Mary from Main Street, trying to distinguish as Daren mentioned, advanced care and planning, advanced directives, goals of care, the legislations around substitute decision making, around consent, and it's quite a complex arrangement, and we certainly need information and tools to help citizens grapple with this and try to better understand the distinction between all the different elements.
Yeah, if I may just add to that, particularly for Ontario, and again, this is province specific, but in Ontario, advanced directives are not a legal entity, nor do I think they're clinically useful. But I want to discriminate advanced directives from advanced care plans. Advanced care plans is that documentation of my values and preferences and my nomination of someone to speak for me. But just because you prefer a medical treatment at the end of life does not equal a medical decision. If I develop Alzheimer's and I prefer a brain transplant, that's not going to happen just because I wish it. So there has to be some contextualization of those wishes to the clinical encounter, to the medical problem, and go through some sort of an informed consent process required by healthcare law before a medical treatment actually becomes, prescribed or indicated. So that's what I was trying to say when I showed that diagram that illustrates the difference between advanced care plan and goals of care discussions. And for Ontario, it's a bit problematic because there's a lot of advanced directive language floating around in the public space, and people do get confused about advanced directives.
Great. So we have one question here. It's a little bit more broad, but it's how do you promote deliberative processes? And also, what are things that people in academia can do to promote the co-production and use of research in government?
Oh, well, good question. In terms of the first one, how do you promote public dialogue or public deliberation? That's quite a good question. And I think if we look at that very specific project when we ask those citizens to about this idea of having a broad public deliberation or public dialogue, I think where we hit a wall is how people frame the issue. For them, having a public dialogue about end-of-life conversation was having a dialogue about personal, private matters. Those their very own personal wishes. So they kind of were quite concerned about that. So I think the way we frame the issue is extremely important if we want to the public dialogue or public deliberation work. So I think framing the issue is probably one of the most important thing that comes to mind. And the second question, Stephen, can you repeat? It was about the use
Yeah, sure. It was what can people in academia do to promote the co-production or use of research in government?
Good. Yep. Good. Very good question. Well, I think one way that we've been doing this, well, it's trying to promote the use of evidence is quite central to the work of the forum. We've been doing this through multiple platforms, from stakeholder dialogue, citizen panels, creating one-stop shop of research evidence. If, again, I return back to the citizen panel project, I think one way that we're trying to do that is trying to summarize the key insights from the research evidence that is published out there into a citizen brief, and then combine this with the ideas, the insights, the values and preferences of citizens. And so that's why it's a form of co-construction. So we're building on what's existing out there and then trying to add the views and values of citizens to that large body of evidence. And one thing that we've been doing lately at the forum is trying to sequence a bit better our citizen panel and stakeholder dialogue, so that we make sure that when we organize a dialogue with health system leaders, we already have the views and values and insights from citizens before getting into a stakeholder dialogue. So I think that's one strategy that seems to be working well, or at least is promising.
Great. And Daren, we have a question for you as well in relation to the publication that you showed and your comment about how decision makers haven't taken up the end-of-life issue in terms of policy making at this point. So what are some strategies to help make sure that they will address this?
Well, I don't know. I'm one of those academics that scratches his head frequently as to how do I get decision makers and government officials to take an interest in the data that we are producing, where we're continually showing big gaps in quality care, and we make it easy for them to sort of embrace some quality indicators, but to date haven't had a lot of the success. I guess the angle I'm working with right now is to work with people and patients to create the awareness and create the demand so that they as voters will try and stimulate interest amongst the leadership and politicians to try and get them to engage. But I don't have a lot of success experiences to share, and certainly would welcome insights from anyone else on the line as to how to be more successful in getting system leaders to take an interest in this space and in the quality indicators that we've made readily available to them.
Okay. FP, did you have anything that you wanted to add to that, in addition to what you've already mentioned?
Nope. No.
Okay. I mean, I know that a lot of aging-related issues, not just end of life, but in terms of healthy aging and other factors have become much more prominent now, especially with some of the data that's been recently released about how Canada's population is now, there's a higher proportion of people age 60 plus than there are of children. So I think, to some degree, I'm sure some of these issues will become more prominent, as a result of that. But hopefully it's certainly an important issue, and hopefully one that as you say, gets more traction on the policy front as well. Well, if there's not any more questions coming in right now, I'd like to thank FP and Daren for joining us today. We certainly appreciate your time and insights on this very important issue. And I would like to thank everybody for joining us as well.